So this is a very timely topic because we now have 4 international randomized phase 3 trials showing that bevacizumab significantly prolongs progression-free survival for ovarian cancer patients. ICON-7 and GOG 218 were upfront treatments. OCEANS was the treatment of platinum-sensitive recurrent disease, and then Aurelia, which eventually got the FDA approval for bevacizumab in this country, was the bevacizumab combination with chemotherapy in the treatment of platinum-resistant disease. And the big question now is, in a disease like ovary where we know anti-angiogenic agents are effective, how can we maximize that? How can we identify the patients who would most likely benefit and the ones who wouldn't? And so there's 3 approaches, and I summarized them in the presentation. First of all, we're looking at a whole collection of biomarkers from many of those studies and trying to correlate that with maximum bevacizumab effect. One approach is using gene expression profiling, which Charlie Gorley has been doing in Scotland, using the ICON-7 specimens, and he's been able to identify gene signatures that suggest there are subsets of patients who benefit and subsets of patients who don't. Work that we've done in my lab has been looking at CD31 expression, which is a protein on endothelial cells, and allows you to really assess the microvessel density of the tumors. And I'll show the data that was presented at ASCO, which demonstrates very clearly that those tumors which have high microvessel density, meaning above the median, those patients benefit the most. In fact, almost all the bevacizumab benefit is in that subset of patients. Both of those studies are intriguing. They, in my view, need to be validated before they could be used. The other 2 approaches to maximizing the effect is, first of all, using new agents. Are there better agents? And I think the answer to that is we don't really know. Certainly there's been a lot of trials using tyrosine kinase inhibitors like pazopanib and cediranib. They show a very similar effect to bevacizumab, but I personally believe they're somewhat more toxic. So the search goes on, and we're not finished yet. We're looking at different agents and different targets. And then the final approach is, can we be clever about it and use combinations of agents? And so some of the easiest and I think most interesting examples of that would be using vascular disrupting agents, which actually disrupt the blood vessels, and combining them with an anti-angiogenic agent like bevacizumab. And there's a lot of preclinical models that demonstrate that vascular disrupting agents will destroy the center of the tumor, but that anti-VEGF or anti-angiogenic agents will take care of the outer part of it. So you combine the 2, you get a better tumor lysis.